We are so glad you are joining us because we've got a really fascinating clinical text to unpack today.
We really do. It's one of those topics that totally flips your understanding of a common condition upside down.
Exactly. So, when you hear the name polycystic ovary syndrome, you naturally assume the core problem is right there in the name, right?
Right. You hear PCOS and your brain just goes, okay, cysts on the ovaries?
Yeah. You picture this highly localized issue. It contained like a purely reproductive thing that a gynecologist would just, point out on a chart, and that would be the end of the story.
It absolutely sounds that way. But an international consortium of medical experts has recently realized that the name itself is actually a massive blind spot.
A blind spot.
Yeah. In fact, they are pushing to change the name of the condition entirely because focusing just on the ovaries, it completely misses the true underlying mechanism of what's happening.
Right. And in the text, they actually propose throwing out polycystic ovary syndrome and replacing it with PMOS.
Yes, PMOS, which stands for polyendocrine metabolic ovarian syndrome.
Which, it doesn't roll off the tongue quite as easily.
No, it definitely doesn't.
But it tells a drastically different, much bigger story about the body.
Exactly. The proposed name change is crucial because this isn't some localized reproductive glitch. It's this complex, full-body collision of genetics, metabolism, and environmental factors.
It's systemic.
It is systemic.
Well,
And to understand why we're looking at a systemic metabolic syndrome rather than just cysts, we really have to look at how incredibly tricky it is to even diagnose, especially when we were talking about adolescents.
yeah, let's get into the diagnosis part because since it's systemic, patients present with this really wide, almost chaotic menu of
A
symptoms.
very chaotic menu. You might see cutaneous signs, meaning severe skin issues like cystic acne or hirsutism.
Which is the excess terminal hair growth.
Right.
Right.
You might see that. Or irregular menstrual periods, severe obesity, and systemic insulin resistance. And yes, sometimes you will see polycystic ovaries on an ultrasound.
But a single patient rarely presents with all of those things at once.
Almost never, which is why the diagnostic criteria are so highly heterogeneous. Clinically, adults with this condition are categorized into 4 distinct phenotypes.
Okay, that's A, B, C, and D, if I remember the text correctly.
Spot on. Phenotype A is the most severe classic presentation. It features hyperandrogenism, which is the excess of male hormones like testosterone, alongside chronic ovulatory dysfunction and the polycystic ovaries.
So that's the full package, essentially.
Exactly. Then it scales down to phenotype D, which is the mildest. That one features just the ovulatory dysfunction and the polycystic ovaries, but without the excess male hormones.
Okay, but when we transition from diagnosing adults to diagnosing teenagers, things get significantly more complicated. The text notes that phenotypes C and D are completely off the table for adolescents.
They are. Only A and B can be diagnosed with certainty in teens.
And let's unpack this for a second, because that makes logical sense. Teenagers naturally get acne.
They do, yes.
And their periods are notoriously irregular when they first start. That is practically the definition of going through puberty. So how on earth does a doctor tell the difference between early onset PMOS and just standard issue adolescent development?
That is the ultimate diagnostic dilemma right there. Physiologic adolescent anovulation, the normal chaotic irregularity of a teen's early cycles, is incredibly common.
Yeah.
And more importantly, it often resolves completely on its own.
Wait, really? It just goes away?
Yeah, entirely.
Yeah.
In fact, 50 to 60% of adolescents with abnormal bleeding will see their cycles entirely normalize within 3 to 10 years.
Wow. So if you rush to diagnose based on a few missed periods, you could be pathologizing totally normal biological development.
Precisely. Half of them just naturally age out of the irregularity as their endocrine systems mature.
That's wild.
And the other factor that complicates diagnosing teenagers is the ultrasound. If a physician tries to look for polycystic ovaries in a young teenager, the imaging is notoriously unreliable.
Because their ovaries are still developing.
Right. Adolescent ovaries are highly active, they are developing, and they naturally look different. They can easily mimic the appearance of cysts.
I see. So because doctors can't rely on the ultrasound and they can't rely solely on irregular cycles, they need concrete evidence.
Yes, they need undeniable proof, which is why only phenotypes A and B are definitive in teens. You need proven hyperandrogenism combined with chronic, persistent ovulatory dysfunction.
You can't just point to an ultrasound scan of an ovary and say, there is the problem.
Exactly. And that diagnostic reality leads us to one of the most significant revelations in this text. If we can't just point to a cyst, What is actually going wrong under the hood?
This is the part that blew my mind. The reality is that there isn't just one single pathway that leads to PCOS. There are actually two completely distinct origin stories.
Yes, two different physiological roads leading to the exact same syndrome.
Let's break down those two roads. The first one is categorized as functionally typical PCOS, and that accounts for roughly 2/3 of all cases.
Right, the majority.
And this typical pathway is driven primarily by a patient's genetics.
And the genetic mechanisms at play here are just fascinating. Through these large-scale, multinational, genome-wide association studies, researchers have managed to pinpoint specific genetic drivers.
Right, they found that specific gene variant.
Yes, it's called DNEND1A.V2. And to understand what this variant does, you have to look at the Hanka cells in the ovaries.
Okay, the Hanka cells, those are essentially the ovaries manufacturing plant for hormones, right?
That is the perfect way to look at it. The Hanka cells synthesize the precursors for hormones. And what this specific gene variant does is constitutively upregulate the steroid-making enzymes within those cells.
Meaning what, exactly?
It essentially locks the manufacturing plant into overdrive, causing these Hanka cells to massively and continuously overproduce testosterone precursors.
So it sounds like there are two different roads leading to the same broken bridge. The typical form is like being born with a stuck accelerator pedal for testosterone, thanks to that gene.
That is a brilliant analogy. The genetic programming itself is hardwired to command the ovaries to overproduce androgens.
Okay, that makes sense for the 2/3 of patients on that typical road. But then we have the functionally atypical group, which is the remaining 1/3 of cases.
Right, and this is where the dynamic takes a really sharp turn.
Because that atypical form isn't driven by a genetic stuck accelerator pedal, is it?
No, it is not. The atypical form is driven primarily by severe metabolically adverse obesity.
And the craziest part of the text for me was that patients in this atypical group actually have a significantly lower prevalence of those specific genetic variants.
Astonishing, isn't it?
That-
Genetics are not the primary culprit here.
So if the typical form is a stuck accelerator installed at the factory, the atypical form is more like the environment severe obesity hijacking the car to force it to that exact same destination.
That is highly accurate, and there is profound medical proof of this environmental process. When we look at longitudinal studies tracking patients with severe obesity and atypical PCOS who undergo bariatric weight loss procedures.
Like a sleeve gastrectomy.
Exactly, like a sleeve gastrectomy. The results are staggering. When these patients lose the severe excess weight and their baseline metabolic state normalizes, the atypical PCOS can sometimes be entirely reversed.
The entire syndrome just
It
resolves.
just resolves, proving that the metabolically adverse internal environment, the fat itself, was driving the dysfunction in those cases.
Wow. Not a deep-seated genetic variant in the ovaries, but the fat.
The severe adiposity was the engine of the disease.
That is a brutal metabolic paradox. But it brings up a crucial mechanical question that we really need to dig into.
Sure, let's hear it.
How exactly does fat physically force the ovaries to malfunction? I mean, if weight or metabolism is driving the syndrome, what is the actual bridge between excess fat tissue and severe reproductive dysfunction?
The bridge is a phenomenon known as insulin-resistant insulin excess.
Okay, hold on. That sounds like a total contradiction. How can you be resistant to insulin and have an excess of it at the exact same time?
It does sound contradictory, I know. But it is the core driver of the biochemical chaos we see in these patients. Individuals with this condition are, on average, one full standard deviation more insulin resistant than would be expected for their specific body weight.
And the text points out that this isn't just a factor for patients with severe obesity, right? Even lean teens with PCOS can have it.
Exactly. Even lean adolescents can exhibit this selective insulin resistance.
Okay, let's unpack the word selective here, because that implies the entire body isn't rejecting the insulin.
That's exactly what it means. Selective insulin resistance means that only certain tissues in the body stop responding to the hormone. Primarily, it's the skeletal muscle tissue.
Okay, so the muscles just stop listening.
Right. Under normal circumstances, insulin acts as a key that unlocks muscle cells, allowing them to pull glucose out of the bloodstream to use for energy. But in this state, the skeletal muscle becomes resistant. It refuses to let the insulin do its job.
So the body's main engine, the muscles, won't take the fuel, and the sugar just stays in the blood.
Exactly. And when that happens, the pancreas, which produces the insulin, panics. The pancreas monitors blood sugar levels constantly. When it sees that the glucose levels aren't dropping, despite the insulin it just relieved, It assumes it simply hasn't sent enough.
Oh, I see where this is going.
Yeah, so it starts pumping out massive, overwhelming amounts of insulin to try and brute force its way through the muscle's resistance. That is where the insulin excess comes from.
But because the resistance is selective, the rest of the body is suddenly caught in a flood. The muscles are deaf to the insulin, but the ovaries and the skin hear it perfectly.
They hear it perfectly, and they are absolutely bombarded by it. And this is where we have to look at how insulin functions outside of just managing blood sugar.
What else does it do?
Well, at abnormally high levels, insulin acts as a highly potent growth factor.
Oh, wow. So what happens when the skin gets flooded with a massive dose of a growth factor it didn't ask for?
In the skin, this excess insulin triggers epithelial hyperplasia, which is essentially a rapid overgrowth of skin cells. Clinically, this manifests as acanthosis nigricans.
Right, I've heard of that. Those are the darkened, velvety patches of skin.
Exactly. They typically form in the creases of the neck, the underarms, or the groin. The excess insulin also frequently causes the formation of multiple skin tags.
And the text mentions that this skin issue is often a massive red flag, right?
It is. It's sometimes the very first visible symptom that brings a patient into a clinic long before severe menstrual irregularities even begin.
So the skin is visibly reacting to the systemic insulin flood, but the effect on the ovaries has to be even more disruptive.
Oh, it is entirely disruptive.
Hmm.
That exact same flood of insulin aggressively sensitizes the ovaries to another hormone called luteinizing hormone, or LH. Remember the Rika cells we discussed earlier?
Right, the hormone manufacturing plant.
Yes. The excess insulin essentially turns up the volume on the LH receptors in those Therica cells to maximum. It hypersensitizes them, which forces those factories to trigger a massive runaway production of testosterone.
That is incredible. So the pancreas is working overtime, desperately trying to feed starving muscles. But in doing so, it inadvertently kicks down the doors of the ovaries and forces them to churn out male hormones.
It's a devastating cascade.
Yeah.
But the biochemical reality gets even more complex.
How so?
Because the fat cells themselves, the adipocytes, are not just passive storage units for excess calories. They are highly active endocrine participants. These fat cells actually express a specific enzyme called 17-beta-HSD5.
Wait, really? So the fat tissue isn't just storing energy?
No, that specific enzyme means the fat tissue actually contains the biological machinery to manufacture its own bioactive testosterone.
Completely independent of the ovaries.
Completely independent, right there in the adipose tissue. And the expression of that enzyme is actively increased by the excess insulin and the increased adiposity.
You know, for anyone listening who is navigating this diagnosis, this biochemical loop has to be immense validation.
Oh, absolutely.
Because it proves this is a battle of rogue hormones. It is not a lack of willpower. It's this self-feeding internal chemical loop where excess insulin and fat tissue are actively manufacturing hormones that work against the patient.
It is a profound metabolic trap. And once you understand that mechanism, it becomes incredibly clear why the ripple effects of this condition extend so far beyond just the teenage years. It fundamentally alters a patient's life trajectory.
And it's deeply embedded in their family tree, too, which we really need to talk about. Because having established this hormonal loop, the text pans out to look at how this impacts the whole family.
The heritability of this metabolic trap is severe. We're looking at a 79% heritability rate in identical twins.
79%. That is huge.
It is. Furthermore, approximately 25% of females with this condition have a mother who also has it. The genetic legacy is undeniable.
And the long-term health consequences of that inheritance are staggering. The text notes that adolescents with PCOS and obesity face an 18-fold increased risk of developing type 2 diabetes compared to their peers.
An 18-fold increase. It's deeply concerning. But it's also vital that we don't just view this as a physical metabolic breakdown. The psychological burden is immense, and it's directly tied to the biology.
Right. The source material shows a 17 to 50% increased prevalence of depression and anxiety among adults with this condition, plus a significantly increased risk for binge eating disorders.
Yes, and when you look at the mechanisms we just discussed, you can understand exactly why. The psychological impact is twofold. First, you have the heavy emotional and social weight of navigating severe physical symptoms.
Like the cystic acne, the facial hair, the obesity.
Right, and the infertility, all in a society that heavily stigmatizes those things. But second, the biochemical chaos itself directly affects the brain. Chronic systemic inflammation and severe insulin resistance are known to disrupt mood regulation and neurotransmitter function.
So the anxiety and depression aren't just reactions to the symptoms?
No, they are frequently a direct physiological result of the same metabolic dysfunction.
The disease just permeates every aspect of a person's quality of life. But here is where it gets really interesting for me. Given the name polycystic ovary syndrome, you'd naturally assume this only affects the women in the family line.
Right, that would be the logical assumption.
But the text points out that male relatives are impacted too.
Yes, this is one of the most eye-opening details in the current medical literature. Male primary relatives, so the fathers, brothers, and sons of females with this condition, are also at a significantly increased risk for severe metabolic issues.
Because, as you mentioned earlier, it's a metabolic and endocrine trait, not just an ovarian one. So
Yeah.
how does that exact same genetic defect manifest in a male body, since they obviously don't have ovaries to take the brunt of the flood?
In male relatives, the shared genetic inheritance presents as an increased risk for elevated androgen levels, which often manifests as early-onset severe balding.
Oh, wow. Okay.
But more importantly, they exhibit that same severe selective insulin resistance. This leads to the metabolic consequences of central obesity, severe cardiovascular risk factors, and a vastly higher risk of developing type 2 diabetes.
So let me get this straight. A brother and a sister could inherit the exact same genetic metabolic dysfunction from their parents.
Yes.
And in the brother, it looks like severe metabolic syndrome, early balding, and a high diabetes risk. But in the sister, because she has ovaries, that exact same dysfunction crashes into her reproductive system, hypersensitizes her the ICA cells, and creates what we've been calling PCOS.
That is exactly the case. And it beautifully illustrates why the experts are pushing so hard for that PMOS name change we talked about at the start.
Right, because it's a genetic metabolic trait that runs in families, simply presenting uniquely in the female reproductive system.
Exactly. It completely flips the script on how we view human health.
Yeah.
It shifts the entire paradigm away from treating isolated symptoms.
Because we're looking at specific gene variants like DEN D1A.V2 acting as a stuck accelerator.
Yes, and we're looking at an insulin paradox, where starving muscle tissue triggers a pancreatic flood, and fat cells operating as rogue hormone factories.
When you understand the why and the how, you fundamentally change the conversation.
You do. It removes the stigma and places the focus firmly on the biochemical reality. It empowers patients and their advocates to seek treatments that address the root metabolic drivers like the insulin resistance, rather than just putting a Band-Aid on the surface-level reproductive symptoms.
Right. It's about fixing the engine, not just painting over the check engine light.
Yeah.
Well, we've covered the mechanics, the genetics, and the environmental triggers today. But before we wrap up this deep dive, there's one final profound concept that we need to explore from the text.
Oh, I know exactly what you're going to bring up.
Yeah, it has to do with how these conditions might actually be taking root long before a patient is even born.
You're referring to the role of epigenetics, specifically the Barkle hypothesis.
Exactly. For those who don't know, epigenetics is the study of how your environment and your behaviors can cause physical changes that affect the way your genes work. And the Barker hypothesis is often referred to as the fetal origins of adult disease.
The premise of the Barker hypothesis is that insults or stresses to the enterouterine environment, meaning the conditions the fetus experiences in the womb, can induce persistent, permanent changes in the developing epigenome.
So we aren't talking about changing the actual DNA sequence itself, right? Just changing how those genes are expressed.
Precisely. If a developing fetus experiences severe nutritional stress, whether that's undernutrition or overnutrition, or if it is exposed to high levels of maternal inflammatory markers, the fetus adapts to survive that specific environment.
It's trying to protect itself.
Right. But in doing so, it alters the way its genes will express themselves for the rest of its life. It essentially programs the child's metabolic responses, predisposing them to complex metabolic diseases decades later.
So the fetus adapts to a stressful environment in utero, but that adaptation becomes a permanent metabolic liability once they're born into, our modern world of abundant calories and low physical activity.
Exactly. The genetic switches have been flipped before they even take their first breath, making them hyperreactive to an obesogenic environment.
I want to leave you, our listener, with a final thought to mull over as you go about your day. If fetal environments can alter gene expression for an entire lifetime, could the massive current rise in complex metabolic conditions like PMOS be a delayed generational echo?
It is a staggering concept.
Yeah. Are we currently seeing the biological results of nutritional, environmental, or psychological stress that our mothers or even our grandmothers experienced decades ago?
The idea that a period of severe metabolic stress 2 or 3 generations ago could alter the epigenetic switches of a family line, making a teenager today genetically predisposed to this exact metabolic trap.
It really makes you wonder, are our bodies today actually keeping a biochemical diary of the past? It is an incredible thought and something to ponder as you continue to explore the intricate, always fascinating complexities of human health. Take care and keep diving deep.